Welcome back to the Catalyst Pharmacy podcast. Really excited because we have a timely episode, in my opinion, with Marc Ost of PioneerRx Shoppe. You know, he's been someone who's spoken to the FTC and things like that, is really involved at state level too in Pennsylvania, part of NCPA, you name it. He's kind of done it, but super prolific and immunizations, and between like him, Rannon, and Scott, and a few others, that there's tons of others too out there. They've really helped us even build out solutions that we have in our own systems, but also like just trying to get other pharmacists comfortable with taking on immunizations. And so he's got a ton of information about like kind of what's new this year as far as like how patients are responding to some of the like newer guidelines, kind of their rush to the governor to make sure that they could secure the ability to still give COVID vaccines, but also just talks through like operationalizing these things and also the reimbursement models. And he's actually doing one of the few people leveraging the new at-home CPT codes for vaccines. So if you're going to do a vaccine in a home, you can get paid at a differential rate under a service code with Part B. So one of the few people actually like doing that live and successfully. So we talked through a little bit too about just kind of what it takes to like talk through your own story with your elected officials to keep telling that story. So and he's going to be at NCPA. I know this won't air till after that, but he's always there, and you can always get through to him via their link on their website too. So we'll make sure that's in the show notes. So we'll take you there now. What I'd like to get going with is like, just like, what are you seeing early right now with patients, with either volume, reimbursement stories, patient stories? Like, I'm going to let you just kind of like open up and reflect on like kind of like the start of it. And you guys are such a different beast in the volume you guys do that I think people sometimes don't appreciate, but just kind of like start in on like how you feeling like the start of the year is going with vaccine season or immunization season. It's summer all year round, and I know flu's coming up, or flu's a year in the middle of flu. So I guess if you can just reflect on that.
Yeah, no, it's definitely been a odd season to say the least. Especially with a lot of the information or misinformation or lack of information that's been out there. It's definitely dependent on what state you're in. Based off the guidance they provided of what you can and can't do, and who should get a shot. We've really tried our best to provide accurate and reliable information to our patients. And our goal has always been, if someone wants a shot and they're eligible for the shot, we want to find ways to give them a shot. We're not here to force anybody to do anything or get a shot. We're going to provide as much scientific based evidence and information as we can to those patients. And ultimately it's up to our federal legislators and boards and our state as well to tell us what we can and can't do. And our goal is to be able to provide those vaccines to the patients that want them and need them.
And I know with kind of the new, I'll just call them, getting the new guidelines in certain aspects of that. Like I'm not saying we got to get political. We can a little bit if we want. But like what, I guess I'm more like interested in this initial conversation around like the patient impact. Are you seeing more folks just ask questions? Are you even seeing a little bit of like, I don't know, this sounds weird to ask, but like mom guilt almost, where it's like, hey, I went and got my kid vaccinated. Now they're saying maybe that was a bad idea. Like, I don't know. Like, how are you seeing this impact patients? Whether it be on the child side or just in general, like me showing up to go get a flu shot.
So I think there's a couple of things. I think the first thing is confusion.
Yeah.
A lot of patients are asking more questions, especially with shared clinical decision making.
Yeah.
To, my business partner, Eric, and our other pharmacists, should I get the shot? Kind of similar situation as it was a few years ago, or is it still recommended? Or, why is CDC or FDA saying this in that sense? So I think there's been a lot more confusion where patients are coming in just unaware of what they should or shouldn't do and asking, their trusted healthcare provider advice. And I also think there's also a fear, there's two parts of this, a fear of missing out, of people are aware that vaccines are going to go away. So I think that a lot of people are coming in to get vaccines because they're afraid that
Oh yeah,
they might not have
you're
access to them.
lose access to them. Okay, I didn't even think about that.
Yeah.
That element.
And the second part is also access. I mean, we've seen with COVID, a lot of the providers in our areas, non-pharmacies, aren't carrying the vaccines, especially pediatricians' offices. So, we've had a lot of patients come in and saying they're at their doctors or they're at a clinic or something in that sense, and they didn't have this vaccine. And, and that's what pharmacies have been able to do, especially ours, is we've been able to, not only stock the vaccine, but we've worked on a lot of different billing mechanisms to make sure that the vaccine's covered. We work with our county to be able to provide uninsured doses to patients that don't,
Oh wow.
well, it's not covered or they don't have insurance. And, again, it goes into the same goal of being able to provide that accurate and reliable information, but also making it accessible. A lot of our vaccines are done in store, but I would say the bulk of them are done outside the store, and we're bringing them to the patients, whether it's a long-term care facility, a business, a church, a synagogue, anywhere and everywhere. It just really depends on if there's demand, and if there's people that want vaccines, we'll find a way, to bring them to them and even to their homes as well.
Is that how you said, like, we can stay local? We can stay like just Pennsylvania with this question. I guess I'm like always curious as to like, in general, like kind of whether it be COVID or others, like vaccination efforts across the state and like engagement at the state level to make sure when certain guidelines were pulled, did you guys have to go knock on doors a little bit and have conversations at the state level to go, hey, look, this is the impact here that you're looking at?
Sure. No, I mean, we were very fortunate that our governor has been very supportive of vaccines, but also of pharmacies giving vaccines. So our state board previously only allowed pharmacists to administer ACIP recommended vaccines.
Okay.
And, our governor was definitely a crucial part of getting the state board to reconvene to allow other competent authorities. And, once they were approved, that allowed us to get the COVID vaccine, because one of the issues was we had the vaccine in our fridge and freezer,
right,
and we couldn't give it because we didn't have the legal authority to do it. And that was rectified, within a few days. And it really, again, it steers down to the patients. We had patients that were coming to the stores wanting vaccines, and, we just had to get some hurdles cleared. But, through the help of, our associations and with our connections, we were able to get things changed in order to be able to provide the vaccines that the patients wanted.
Got it. Did that evolve into, well, I don't know, you're so kind of like cutting edge on this, and maybe it didn't evolve into this conversation, but did that evolve into like the reimbursement models at all being discussed while you're also trying to just get access as well for the patients too?
Absolutely. I mean,
okay.
The biggest tie-in that we have, I mean, look, Rite Aid, 1/3 of all Rite Aids are in Pennsylvania.
Right.
And Rite Aids, to their best, they did a lot of vaccines. So one of the things that we've told a lot of our legislators and, the governor and anybody who will listen is, if reimbursement isn't fixed, these pharmacies are going to continue to close, and patients aren't going to be able to go into these pharmacies to get vaccines. While vaccines may reimburse properly, there's still a larger issue with PBM reform and just getting paid fairly for the not only the medication, but the services that pharmacies are providing. Yeah. So it's definitely, it goes hand in hand. And, vaccines, I would say, are a example of what pharmacies can do. And I think that overall, especially, in Pennsylvania, we've shown the impact that we can have in being able to provide vaccines and being able to, whether it's during a pandemic or just to a school district that's having problems getting their kids vaccinated so they can return to school. I mean, they're turning to pharmacies, and we're the ones that are delivering results to them.
Yeah, honestly, that's our whole neighborhood. That's like, I always like, I'm the weird dude in my neighborhood who's like, where do you get your vaccine? Good. I mean, like, people are like, oh, what do you, I mean, I guess the farms, like, almost everyone I poll now though is like, yeah, we just go to our farm.
And I think one of the, it's interesting you say that. I think one of the things that's changed definitely over the last 5 years, is where pharmacies were kind of, I don't want to say the main vaccinator, where people, said, oh yeah, my pharmacy might do it. Now it's almost like, okay, well, if I need a vaccine, I'll just go to the pharmacy. It's like second nature.
Yeah.
And we get a lot of calls and requests for vaccines that we don't have, that we certainly try to get or, try to help with. But we kind of become that vaccine hub in the community. A lot of pharmacies across the state have done that as well.
Right. In that sense, like you kind of mentioned that vaccines are reimbursed properly. Is that true in
Sometimes.
Pennsylvania? I was going to say, like, can we like discuss that a little further? Like, I feel like that's one thing they've been. I say they, as in like it's this ominous group, but like I feel like they've been kind of chipping away at a little bit from a reimbursement model perspective, and like that's something that truly is measurable from both the health outcomes perspective, but also like the level of service / activities in the pharmacy that have to happen to even make one actually go in and shot in an arm. So I guess I wanted a little bit of from you if I could get like state of the union on what you're seeing just from a reimbursement model, even if it's just Pennsylvania specific.
Yeah, I mean, I will say I've been pleasantly surprised this year. I thought that there would be more issues with reimbursement and coverage to that extent, but overall, it's been relatively the same as similar years. I think one of the biggest differences, a lot of vaccines we bill, I would say over 60% of the vaccines we bill are on the medical side. And
Oh,
when you
gotcha.
bill on the medical side, you're bypassing PBMs. So now there's no middleman between you and the insurance company. You're billing the insurance directly for those. And there's benefits to billing medical. There's sometimes disadvantages as well. But I think that having that ability to do that is definitely key. And I think the other thing is that we find synergies within the industry that really want to help us vaccinate. So that could be our GPOs that certainly provide a lot of education and do different things, but also manufacturers. I can tell you, we work with a lot of different manufacturers where they want to know about coverage. They want to know, hey, are these patients able to get it? Or they have teams of whether it's people that do strictly deal with insurance, or even lobbyists that deal with legislators that kind of again, if it's not covered or we can't give the shot, it doesn't benefit them. So we've formed a lot of synergies with them to be able to help them, but also help ourselves as well to make sure that coverage is there and that access is preserved for these patients.
Yeah. Okay, cool. I was trying to understand that. Speaking of like medical side of the house, I guess like you're one of the folks I know is always kind of like just doing all sorts of stuff. Like people come to you to go, hey, am I billing this right? Things like that. Like integrating that into workflow and making that almost like, I guess, just like part of your workflow to a point where like almost the people who need to be like thoroughly trained and can do it really, really well from a day in, day out perspective. I think you do a good job of that. You also have a good amount of volume for that in order to like make that a core competency in your pharmacy. But I guess like speak to, I guess kind of like even your own growing pains when it comes to like just billing on the medical side. Um,
Yeah, no, I mean, I think there's the first thing that I'll say is one of the things that we've done is we've kind of designated Pioneer as our central hub.
okay.
So any vaccine we've given is recorded in Pioneer. I mean, there's plenty
It's
of,
still going in there no matter what.
no
Okay.
matter what, there's plenty of EHRs and platforms that say they can just take care of it and I'll bill it. But what we didn't want to get into a situation where we had one vaccine over here, another vaccine over here. So Pioneer is always our central data hub where everything has to go in there. A lot of features and tools within Pioneer that certainly make it a lot easier to bill. When you use an intermediary, there's a bin PCN that will translate it from the pharmacy claim to the medical claim. We've used TransactRx in the past and we use DocStation, and both have been really great at not only sending claims to the correct payers, verifying eligibility to make sure that the IDs are correct, the date of births are correct, all that, but then also tracking and in the end of making sure that we're actually getting paid for those claims. Because, if we're doing all this work, we want to make sure that we're getting paid for the claims that we're doing. And I think that there's been a lot of improvements to both systems to make sure that things are going to the correct payers and that they're going correctly. And, ultimately, again, that you're getting paid for those claims. The other thing that certainly made it a lot easier is, a lot of tools that Pioneer developed over the years. I think that Radin, Scott, and I, we had like a 3 a.m. email chain where
Yeah.
we
We've
were,
been on a few of those.
yes,
You're right.
we were sending ideas. And I think the testament to Pioneer is that a lot of these things were implemented. So it could be templates. I mean, our policy with our staff is our templates are based off the lot number. So literally, and we still have paper forms for every shot we give. So if someone picks up a form, they look at the lot number, they type equals 3032967, and that's going to pull up that template specific for that lot number for that vaccine, billed to the correct quantities, expiration dates correct, everything that's needed is in there. So it's, 2 clicks, really 2 or 3 clicks. And our staff has done a really good job of managing that and being able to bill it. And, look, I think we do a lot of vaccines. I mean, we always go back at the end of the year and we find things where, hey, this wasn't billed right or, whatever it is. And that's time that we can do kind of in the off season and be able to do that. But, overall, I mean, we plow through a lot of vaccines and it's a staff managed project where they know what to do and they're able to set it up and they're able to keep it organized. And we're always able to, we also, as I said, we have paper forms for every vaccine we give. One of the other things that we certainly try and do our best of, we have workflows in place to make sure the right person's getting the right shot. So when we go in our in-store clinic, we have different colored bins for different colored shots. So we're making sure that if someone's coming in for Moderna mNEX spike, they're going to be in a red bin. If they in a red bin and they pull out a Shingrix or whatever it is, we know that's not correct. And then even in our offsite clinics where we're doing thousands of shots, we have different colored forms. So someone might come to the table with a white form and a yellow form. That means you're getting a COVID and flu shot, or we might segregate the sections. So there's a lot of kind of little checks and double checks and triple checks too, to make sure that the person that is signed up for the shot is getting the right shot. And then also done in advance of just qualifying the patients for those shots, making sure the eligibility, making sure it's the right age, making sure if someone's getting an RSV, is it covered? Did they get a previous shot? Pneumonia. I mean, our staff spends a lot of time of going on our registry, going on our Medicare jurisdiction portal, and making sure that that the correct protocol is followed to make sure the patient needs it. Because and I think there's 2 parts to that: is you don't want to give the person the wrong shot, first and foremost from patient safety, risk, and health. But also is you also don't want to give a patient a shot that you're not going to get paid for too. That's $300-$400. So there's a lot of tools, definitely things that we've helped develop, but also have utilized within our store to really make it a very smooth and efficient process.
That's huge. We have so many. It just makes me think through like all of the different workflow things that you're talking about doing it, but also it made me go back to like we still have, I don't know, I'll just say thousands of pharmacies still not immunizing at all. And I'm sure that everyone has their own like probably reasons why to a degree. And sometimes it's in a health system and not applicable because somebody else does it. But also I think some of it, a good portion of it is just like not knowing where to start to a degree, but also looking at like, man, these aren't cheap things you're buying. There's different storage requirements, along with all of the things you just talked through to try to do it at scale and do it at scale safely and effectively and making sure you're getting comp for it. I guess I'm gonna have a really stupid question that I'd like to understand, but also like if you can answer that question, but then also like kind of talk through if you're somebody new to going, hey, I want to start a program, where do you kind of start? And I'm sure that's probably local specific, but there's a little bit of like, I think, I know I'm dragging this question out, but like maybe a misunderstanding or like what the even reimbursement timing is for some of this stuff. Like when you're sending something to the medical side, what is the difference you see between getting paid for a pharmacy claim than you are getting paid for a medical claim? And like, how does that factor into like your own inventory or like how you manage that from that perspective? And then I guess if you can like lead into, if you were brand new in a fresh market, having to do this all over again and start something from scratch, how to do it in a way where it's like, you think you can win and it not be the biggest investment that possible, I guess.
Yeah. I mean, I'll say this, one of the things, I'm on a NCPA Developing Opportunities Committee, and I've been on that committee for a while now. But one of the things we do at the beginning of the year is we kind of look at different opportunities and say what's easy, medium, and complex. And one of the easiest things and lowest barriers of cost to entry is vaccines.
Okay.
It's
So it's really low barrier, to be honest.
Yep.
Okay.
Yeah, I mean, compared to some other, more complex things, it's finding out what requirements your state has. Do you need a standing order from a provider? Do you need to be licensed to administer? And and then billing. Do you have a PTAN for Medicare? Do you have a medical billing capabilities? If you need it, I mean, a lot of the things can be done on the PBM side as well. But it's not complicated. I mean, it's something that there's already roadmaps set in place. If you're part of CPSN, one of the requirements for CPSN pharmacies is that you have to have the ability to vaccinate. And, I think one of the biggest benefits that I've seen from CPSN is the information sharing. So, our local network in Pennsylvania, PPCN, I know if we're starting a new project, if we're going to be doing IV infusions, if we're going to be doing, anything, someone's probably already done it or has tried it and can give us a playbook and context and say, here's what to do, here's not what to do, and and the best way to do it. So that blueprint's definitely out there. A lot of state associations really have great quote tool guides as well, as far as what you need to do. The second part of it, the payment, I mean, I think as you start to scale, one of the things that I think is one of the biggest benefits of vaccines is that you can bypass, and I'm not saying this in a bad way, wholesalers as well, because most of the manufacturers sell directly to you.
Yeah.
I'm actually presenting at NCPA about maximizing pharmacy purchases with credit cards. And if you ever see my wallet, you see my stack of credit cards. But, your typical wholesaler terms might be net 10 or, net 15 and something in that sense. A lot of vaccine manufacturers are giving you net 30, net 60. And if you have the ability to pay with a credit card, that's adding another 30 days. So, I could be buying something today.
Fair point.
Billing
you can
it
90-day terms basically then.
Correct. And not having to pay for it for 90 days. And
right.
I mean, again, as you start to scale, these vaccines become very expensive, and it's cash flow, it's revenue cycle management, and it's also inventory too. I mean, knowing the storage capabilities, what gets stored in the fridge, what gets stored in the freezer, and how long is it good in the fridge, but making sure that your staff knows that too, or a dedicated staff person, because I've seen a lot of pharmacies, I've seen a lot of facilities, I've seen a lot of doctors' offices have so much waste because they just didn't understand the process of what to do. And, I would get a call and say, hey, can this be used? And it's been in the fridge for 61 days. No, it can't. It's something that you should know, and something that, so having those SOPs to know all these things and making sure that you have all your, operations buttoned down is if you have a power loss. I mean, we've had this happen during a hurricane where and we're fortunate now, we have a lot of backup fridges, freezers,
redundancy and all of that now.
So we know, I mean, if the power goes out and the fridge gets below a certain temperature, I get an alert on my phone. We know exactly how much time we have. We have all the capabilities to move the vaccines to different places and to keep it remote with us if we need to. And just understanding, because again, they're expensive. It's inventory. You don't want to waste it. We want to put it in arms, not just let them go bad.
Yeah. Okay. Gotcha. Oh, I feel like I got an answer on the timing. Like I even had the reason I asked that, a pharmacy asked me this, and I actually didn't have an honest answer yet. And he was like, what is the difference between like medical billing timing on payment versus like, they're used to sometimes 14 days to 30 days in the PBM world, sometimes longer, but like for the most part in that bucket, is it about the same, or is it?
So Medicare Part B,
yeah,
Medicare Part B is quick pay. So that's 14 days from the time they receive the claim. Now, when I say that, it's important because if I send a claim today, that doesn't mean the intermediary sends that claim the exact same day. Some intermediaries hold claims for 2 days, some hold for 7 days, some hold for whatever. I mean, and that's something you should be able to ask your intermediary and find out. But within 14 days of receiving the claim, you'll get paid for Medicare Part B as in boy. Some of the other medical insurers, it really depends. We've seen some as quick as 15 days. We've seen some take 60 to 90 days. Now, again, your intermediary and or you should have a way of tracking those claims. So our staff logs on to our DocStation portal and looks at the claims and saying what's pending, what's rejected, what's failed, and we can troubleshoot those claims right in there to whether it's send it to the correct payer, correct the subscriber ID or whatever it is, but just having someone that can monitor the queue. And same thing we do in Pioneer too, is making sure that our queues, whether it's in the pharmacy or specific to vaccines, making sure those queues are being checked and cleared as much as we can, so that things aren't getting lost in translation, and again, we're getting paid for the services that were provided.
What about how you're thinking that all makes sense? Like, I know for some people listening or watching, they're like, Mark, I know all of that already, but like, there's people who don't. So, and I mean, they're probably saying that to me, not you. Since we have two Marks on this podcast today, I guess like there's also the element of, I think once you begin to scale, like you're saying, that also to me opens up, like, to me, I'll just say competency in like, and comfortability going to probably larger scale, either employers, clinics, you name it, like other types of like venues from that perspective of like, hey, look, you want to go put 50 shots in arms at once somewhere. Obviously that takes inventory and all of those other things, but like, what about just when it comes to having those conversations, either with those entities or even with your public health departments and things like that, is like, how crucial is it to have a relationship with your public health department, but also, what does it take to really have those conversations from like either it could be employers, it could be a nursing home, whatever, like, what are they looking for? Like, if someone who's got a little bit of volume now and they're like, hey, look, I think I can actually go help somebody. I mean, I know a lot of these pharmacists totally are well networked in that way. They can make those introductions themselves, but like, what seems to be important to, I guess, that other stakeholder that you're talking to?
One of the most underrated, probably I'll say tools is the preparation. We were at we have 3 vaccine clinics offsite today, and our first 2 vaccine clinics. And one of the things that people keep saying, you guys are so organized, you're so prepared, because we don't want bottlenecks at registration. We don't want people coming in and saying, am I eligible for this? Should I get this? We do as much as we can in advance, and we have those forms printed out, we have them sorted, so that when they come to get their vaccine with the vaccinator can literally ask them a few questions, give them the vaccine. And I think bringing administrative staff to those clinics is extremely important. Another clinic we had the other day said, oh, it's usually only one pharmacist. Well, if one pharmacist is giving a vaccine and has to check people in and do all that stuff, it's going to really slow down the process. So, we have 5 or 6 full-time staff that at this point only does vaccines, and they make it extremely easy for our vaccinators, but more importantly, they make it extremely easy for the facilities that we go to, the businesses that we go to, we do a lot of homebound vaccines for those patients as well. And
oh, you do? Okay.
Yep. And I think that's really key, is doing it in advance, being prepared, and just making it as an efficient process as possible. Because, if you talk about one of the things that that I've learned over the years with vaccines, if vaccines are a pain, so, there could be a lot of hurdles to someone getting a vaccine. It could be insurance. It could be they don't want to go to the doctor's office. They don't want to wait an hour. It could be they had a bad experience at a pharmacy or somewhere, and they just don't want to sit. They want to get in their vaccine and get out. So that's kind of been our, goal all along, is how easy can we make it for somebody? A patient walks in their store. I mean, literally my staff types a lot number in Pioneer. 3 clicks later, they get a label, put that label on the form, and they're getting a vaccine. So, I mean, they can be in and out in, 10, 15, 20 minutes or so. And it's very quick process, but I think more importantly, it's a process that works and that verifies everything that we need to, that we're asking the right questions, that we're making sure the right person's getting the right shot. And, ultimately, it's a process that, that our staff really has done a great job of scaling, to say. I mean, we've done clinics where we're, done 200 shots in 4 hours.
Wow.
And
yeah.
And, it's, and no one's waiting. It's smooth.
That's how you get invited back too, right? Like they're not looking for someone else next year to do this. They're like, hey, we're just calling Mark and the team.
Yep. And being able to give them what they want. I mean, that's, I think, no different than any other business. From, a facility standpoint, we've found that facilities are usually understaffed, and the reason why they're using us is they don't want to do it themselves, even though they probably could. So how can you make it easy for them? What reports can you provide them? Okay, can you can you qualify patients? Can you do this? Can you give them proof of vaccines for their employees? And that's the other thing too. I think one of the key things that we found with facilities is, while we want to do all the residents because they're over 65 and it's billed Medicare, is being able to take care of their employees, being able to give them doses. I mean, again, a lot of the facilities that we deal with have a lot of uninsured patients. So if they're in certain counties, we can help them with uninsured doses, and we can administer the vaccines to their employees and make it easy because of requirements they have. So, how can you help them meet the requirements that they have with a reporting standpoint, or, anything they need to stay in compliance?
Yeah, there's nothing like probably a facility calling you and you go, hey, I can do all the Part B stuff, but I probably can't help you with your uninsured patients and all of stuff. Like that's probably a great way to go. Man, I'm just, I'm going to go try to find somebody else in that way. So like, yeah, when everything's a yes and you can check every checkbox, that's huge. That makes sense. That's something I didn't even think about.
Yeah. I mean, that's kind of, our dynamic within the pharmacy, with Michelle and I and with Eric. Eric doesn't say no to anything in the pharmacy, but I don't say no to any opportunities. So if someone calls and says, I want 10,000 vaccines tomorrow, Eric might not sleep for a day, but my job in our partnership is, okay, we'll do it, but we'll figure it out.
We'll get it done.
Between Michelle and I, we're able to find the people that we need and to, figure out ways to get things done.
We'll get Eric and team some sleep.
Eric doesn't sleep he likes to worry.
He doesn't sleep to begin with, I don't think.
Yeah.
You talked about at home for a second, and I wanted to just kind of like drill in on it. Can you explain more or elaborate more on like it sounds like a vaccination program in the home?
Yeah. So for a lot of our homebound patients, I mean, this was something that started during COVID. There's a lot of patients that couldn't leave their house that we just did because that we felt that was right to do for the community. Medicare added a CPT code for at-home vaccination, M0201, that you can bill. So if someone's getting a COVID, flu, or pneumonia shot, there's an additional payment that can be billed to Medicare for those vaccines. But then the second part is that we work with 2 of our counties to be able to basically run their homebound program, where a lot of patients are calling the Office of Public Health from their county, and then they're referring that to us. We've even had some grant programs where they're able to reimburse us for, expenses and mileage and all that stuff. So we're able to send a pharmacist or nurse to those patients. And, especially now, I mean, we're actually having a hard time keeping up with the demand because there's a lot of homebound patients that want vaccines, in the season. But, I think that there's multiple factors, but I think one of the factors is these patients don't really have anywhere else to turn. You're not going to see the large chains go to
you're not going to see them do this. 100%. And or health systems either. Like, you can't see that happening either.
Yeah. And then it's a revenue opportunity that we certainly, welcome. And it's also patients. I mean, no different than patients coming in our store this year. It's patients that want us to come back next year. It's patients that call us
or transfer prescriptions to you in some way. So
exactly.
A little bit of an audition in that way, as well. Wow. Okay, cool. So I didn't realize it. I heard about that CPT code. I just didn't know of anybody actually like using it and billing it. So you guys are actually like no problems there. No issues with getting that billed and paid.
If it's billed to Medicare Part B, there's no issues.
Okay.
I mean, one of the issues is that we haven't had much success with Advantage plans paying that
really?
code.
Okay.
It's something that we're working on. But again, if a patient wants it, we're not going to tell them, no, we're not coming out there because your Advantage plan.
Yeah, because you're on an Advantage plan, right? Like, it's tough.
So, and that's and kind of it kind of all ties in together too, because one of the things that we do, I mean, Eric, my business partner, is a licensed insurance broker, so he can talk to people about their Medicare Part D plans and recommend, and it's no different than a lot of the other conversations that other people are having. We're not always the cheapest pharmacy, but there's a premium to pay for, and we give the patients the options, and we're honest with them. If you want to use our pharmacy, it's going to cost X, Y, and Z. If you want to use, CVS or no chain, it might be $100 less total, but they're not going to be able to provide the services that we
Who's
provide.
coming to your like if you're kind of homebound and all of that, like who's coming to your house to do all the other services or whatever?
And it's all the services that pharmacies are provided that we're not reimbursed for under the PBM side.
Yep, absolutely. Okay, all right, that was cool. Like I haven't heard too many like I've heard success stories about folks doing that. Like I know they developed a payment model, and I just haven't heard anybody like actually leveraging the payment model now. I didn't know about the MA struggles though. So that's something interesting. I got to figure that out. Okay, all right. And even on the MA plans, is that still? I guess it's through the medical benefit, but it's not Part B.
It can be either or. So a lot of these have a Part C plan where they take that claim and translate it. We're diving into billing the advanced plans on the medical side more and more often now.
Okay.
And sometimes seeing higher reimbursement.
With success, just it's slightly trickier, I guess, in some way.
Every year it's a lot of the similar things. It's trial and error where we may have a patient that has, commercial insurance through Optum and insurance through Independence Blue Cross. And we look at those claims and we might submit one claim to each of them and say, okay, well, we're getting $60 more on the insurance side. Why should we bill on the PBM side? But a lot of times it's also forced too, where the PBM will say medication administration not covered and you have to bill medical. It's figuring out. I think that we're resourceful. We have relationships with a lot of our insurers. We want to get, do the right things. And so I think it's just a matter of just going through the start of the year and figuring out what's the best way to do it and, and teaching our staff that.
We're about to be so I want to talk about a few things that you're doing. So is there anything else I'm missing on like start of vaccine season? Like, this is just always like a really good timely, like this is your annual spot if you want it. If like, is there anything else I'm missing like to think through or talk about that I didn't think to bring up when it comes to immunizations or operational, whether it's operational, legal, regulatory, or anything like that I missed?
No, I think the key is that it's definitely worth your while. And that there's, utilize the tools in Pioneer because, 6 years ago, 5 years ago, there was so many different systems that weren't intertwined or connected. And now we can click 3 buttons and we can bill, report, and, adjudicate all in the same thing. And it just makes it extremely easy to be able to provide, a lot of vaccines and do it properly.
Yeah. So the operational barriers aren't as probably steep as they were before. From that perspective, it's just like, sounds like committing too. Like there's a little bit of like, yes, you should pregame as much information as possible, whether through your state association, CPSN, NCPA, you name it, there's resources out there. Then once you buy that stock, that's like, hey, now you got to commit. And cause you don't get to buy those. Some you get to buy single doses. Most of them, I don't think that's true though.
Some, yeah.
Yeah, some you do, but most that's not true.
And it's also, one of the benefits that we've seen too, obviously the bulk of our business is seasonal, but after flu season, you have RSV, you have pneumonia, you have shingles, you have Prevnar, so you have all these vaccines, especially that now 50 plus population needs. So we can focus on a lot of the, the non-respiratory vaccines in the off season and, be able to provide those vaccines and, focus on a lot of the respiratory vaccines during flu season.
Yeah. I was going to ask you about RSV in general before I move on from vaccines. I'm not really moving on from vaccines, but I want to talk through about like what you're doing with like you've spoken with the FTC and stuff like that. So I want to get into some of that. But I was going to ask about like RSV specifically. I just seen like, we had that big surge when that vaccine first came out. And I feel like it's just been a little bit of like, hey, like I wouldn't call it gradually fell off a cliff, even though that's kind of an oxymoron, but like I just haven't seen the sustainability. And I think some of that was COVID fueled, I'm sure. But like, do you have an opinion or insight around like that vaccine specifically?
I think there's, again, I would say lack of information. So there's 3 good vaccines that are out there. One of the things that we've seen a lot now is patients coming in for an RSV vaccine, even though they've been already vaccinated. So, we do expect them to be able to receive another dose. It's probably sometime in the next few years. It's not authorized yet. So if you have one vaccine that you're considered protected and covered, and your immunity is still there, I think there's not a lot of known factors as far as the ages of what it's approved for. So now that 50 and up age group, with the pre-existing conditions and comorbidities, and one of the things that we like to tell patients too is, while RSV may not be as deadly as some of the diseases, there's also no treatment for it. It's not like if you get COVID that you can take Paxlovid. If you get flu, you can take the antivirals.
Yeah,
you have RSV.
There's nothing to improve your odds once you get it, right?
Correct. If you have RSV, you're going to take comfort meds just to make you feel try and make you feel better, but it's not going to do anything to attack the virus.
I'm an adult who had RSV at one point. Like I got it. Like I think I was 29 or 30. Dude, I thought I was going to die, man.
Like, I had it last year.
You did. Like it hit me like a brick wall, man. Like it was worse than any flu I've had or COVID I had. So
yeah. So I mean, again, if there's a vaccine there I think there's again 3 options for the vaccine, but it's a vaccine that has a lot of great studies and research behind it to prove the effectiveness. In my opinion, if you're eligible, there's no reason not to get it.
Am I eligible if I've gotten it before? Like, am I eligible? I would get that in a heartbeat, man. It was so bad. Anyway, just like I've had shingles already, and I'm not anywhere near 50 yet. I'm probably much closer now than I just said. Like I think I had it when I was in my mid 30s too. So I was just like, man, I don't know what's going on. So I was just like, man, all right. And none of those are fun. Okay. Anyway, so I guess I want to move on to like a little bit of like how involved you are in general around, like, I know you work within CPA, CPSN, PPCN, and folks who don't know what PPCN is, I think that's Pennsylvania. Is it Pharmacists Care Network? Yep. Correct. Okay. Yep. And all of that. So, and you've spent time with like the FTC chair, state stuff, attorney generals. We already talked a little bit about like working with the governor. I guess, I wanted to just like understand a little bit of like, hey, what is your end goal? But also like, and I'm sure it's just to drive change probably as much as possible around an awareness, but what have you seen in speaking with, I'll just say, like, I know you're part of all of those groups with a bunch of great other smart pharmacists and pharmacy owners. What's it like speaking to like your FTC folks and your governors or the people who are working for those people or whatever? Like what's kind of your mission? Like, I guess your message to all of us who, like, if you get that opportunity, this is how I approached it. And this is, it's more about education than it is about trying to be prescriptive.
Yeah. I mean, I think I think the first thing is, we're dealing with patients here. So while we're talking to these elected officials, as a pharmacy owner, if we fail to exist, we can't serve those patients. So a lot of the things that we advocate for is, sure, we want to get paid fairly, and we want to have PBM reform and transparency and all that. But the reason behind that is because we want to continue to serve our patients. And one of the best examples that we give to a lot of our elected officials is the predicament that when you bill a patient's insurance for a drug that you're going to lose $300-400 on, can you continue to fill that medication? And if you can't, what conversation can you legally have with that patient?
Right? Yeah. The
PBM contracts restrict us on what we can and can't say. And, we do the best to our ability to communicate with the patients in ways that we can help, but we also want to be able to, provide solutions to those patients. We don't want to just give a patient a script back and say, we can't get this for you, and you have to go find it yourself.
Yeah.
We try and find solutions to that. But it really just comes down to, being able to exist and being able to continue to serve our patients. And I think that really hits home, especially with a lot of our elected officials when they see things in the news. I mean, the Rite Aid closures, as I talked about before, has had a huge impact in Pennsylvania. I mean, we have a lot of counties that don't have any pharmacies, where Rite Aid was the last pharmacy there.
Really?
And one of the things that our elected officials have seen in Pennsylvania is pharmacies aren't going to open up in those areas. If Rite Aid has the
scale, right? They
scale, buying power, and everything. Yeah. And if they can't survive, then why would a small independent be able to survive?
How do you make a good business case to do that?
Yeah.
That's fair.
And I think, overall, it's not a Democrat or a Republican issue. I mean, it's something that has pretty much widespread bipartisan support. I think that community pharmacies are well liked. And I also think that our politicians are now a lot more educated than even when they were 2 or 3 years ago, where, if you said PBM, maybe they knew what it was, maybe they didn't. But now everybody knows what a PBM is. Everybody knows what they do and how they add cost to our drugs. You look at a lot of these drugs where it's so much cheaper to buy it overseas, or it's even now cheaper, these direct to consumer programs from manufacturers. Well, the only reason they're doing that is because they're bypassing the pharmacies too, but they're bypassing PBMs. But what's the frustrating part is I can't go and buy, something from,
you can't go buy that drug
at that price
being
to
direct
be able to dispense it.
at that. Yeah, 100%. You can't. Yeah.
So it's a system that's, broken. And the thing that I always try and gear toward with, any of these conversations is transparency. If transparency existed throughout the whole supply chain, from pharmacies included, from the pharmacies to the wholesalers, to the PBMs, to the PSAOs, to everywhere, you could see exactly where the money's going. You could see exactly why, a GLP-1 costs $1,200, but it only costs, a few dollars to make. And you can see why that price is so high, because there's rebates flowing in so many different ways that transparency doesn't exist. And while, NADAC, the National Average Drug Acquisition Cost, it's not a perfect science, but, that's why you see a lot of the Medicaid plans, especially the fee-for-service plans, that are paying a NADAC, which in essence should be your acquisition cost plus a fair dispensing fee. And I think that's the key for the system to be fixed, is there has to be an increase in transparency. I mean, we've heard from employer groups, we've seen, governments, we've seen elected officials ask for the true net cost of an item, or how much does something cost. And a lot of times they can't get answers. I mean, even the FTC.
Yeah, everyone has a different answer, because your true answer to you is different than the true answer to like what pharma thinks and what the wholesalers think, and like it's the system we have.
Yep.
Yeah.
But I think transparency throughout everything is key. And one of the things that I'll say is, if your pharmacy isn't willing to be transparent with elected officials, we've heard that, well, NADAC doesn't include your rebates, or NADAC doesn't include this, or, pharmacies are making money because they're getting rebates from manufacturers. Look at our invoices. Look at our, we'll open our books and we'll show you everything that you need to know to see that, that we actually are losing money on the script, and we actually are getting paid below their acquisition cost.
Yeah, it's not a shell game.
Yeah, and I think explaining to these, to the politicians or legislators or whoever it is, that it costs. I mean, I would say $10 is a low figure, but if we're not getting paid, our margin isn't $10 on a script, we're losing money on those scripts.
Yeah,
with the cost of the pharmacist, with the cost of rent, computers, electricity, the computer system, everything that goes in it, switching fees, labels, all that. And I think pharmacy is one of the only businesses where we don't have the ability to increase our prices.
I know. Yeah.
It's not a free market. So, you look at labor, you look at inflation, you look at all these things that have gone up over the past few years, but our reimbursement has gone down, and we don't have any ability to change it.
So your perspective, just to sum it up a little bit, is like, make it about patient impact. Like, whatever the message is, wrap it around patient impact, really. Like, if the message is like, hey, look, we're being reimbursed on these types of brands or this drug class or whatever it is, in such a way where it's unsustainable, don't just stop there and then continue and go, and this is the patient impact if this continues in some way. So that's kind of how you would structure.
And I think, like, this is, I have these with me. These are just a year's worth of thank you cards for patients.
That's so cool.
Really?
And that's awesome.
And I think it's good for, obviously, Eric and I, we read them, but our staff too, because it shows that you're appreciated. And I think that when we can go into a legislator's office and show them this and say, okay, well, if we don't get PBM reform passed, or this isn't fixed, or we don't have the ability to vaccinate, these patients are going to be stuck.
Yeah, you literally fan that out and go, this doesn't happen at other places too, right? Like this that happens in community pharmacy where you're just powering a additional level of service, or I'll say differentiated level of service for usually the more complex patients. So anyway, whatever. Like I know I'm just beating on a soapbox. Everybody already knows. Well, good stuff. Okay, I was wanting to understand. Like you've spoken to so many different like rubbing elbows with all those higher ups out there, elected officials and stuff, and we need an army of folks just like you. Personally,
and I mean the best advice I can give somebody: invite them to your store. I mean, we've had so many officials come into our store and just see the things that we do, and it's you don't need to put on a show. You don't need to do anything other than what you already do. And it's like, I forget who it was. One of our officials like, "Oh, you guys deliver? How much do you charge for delivery?" We don't charge for delivery. How much do you charge for compliance packaging? We don't charge for compliance packaging. How are you doing this? Well,
you won't let me.
Exactly.
You're right. There's a little bit of like, you won't let me. By the way,
and that's the thing is unless these things change, a lot of these services are either gonna have to charge for it or they're gonna go away.
Yeah. Well, that's cool. That's a good message. Well, good stuff, man. Well, I think that's it for me. Is there anything else I'm missing out of there? Is there anything in the pharmacy also, like you're just in, like, I know this is more of a immunization / what you do episode, but like, is there anything inside the pharmacies that you're thinking about at the moment, outside of like vaccinations and things like that? Or I know right now in the middle of this season, probably not, but like from a long-term perspective.
I think one of my goals as a non-pharmacist business owner is I always look at efficiency. And one of the things that we've started, probably started about a year ago, was working with RX Mile. And that delivery system has definitely been a dramatic increase in efficiency on two sides. On one, the preparation for delivery, where it might have taken 3 hours, we're now down to probably about an hour. And then two, on the delivery side of being able to capture all of this on a electronically, having the maps routed out, having multiple drivers, being able to access it in a cloud-based system, and then also having that audit. Obviously every pharmacy gets audited, but having that audit track of it was delivered to this patient, here's a signature, here's a picture, here's the longitude, latitude, all these things where it's, basically foolproof at this point.
Yeah, so, full confidence in like being able to go defend it in any type of audit as well.
So, that's those guys have been really great to work with. They've certainly developed a lot of things that we asked them to.
Yeah, great. Good.
Yeah, and it's made it a lot more efficient from our standpoint, which also saves money too.
Yeah. Again, efficiency, right? Like, yeah, no, that's a huge win. That's good. They're a great group. In general, super smart, super ambitious, as well, and plug in gaps where, we haven't had the bandwidth to try to update as well. So that's great. They're a good group. Good stuff, man. Well, dude, it was great to like, I think this is mine and yours first. Is it mine and yours first? Probably for me and you? Like,
I think so. Yeah.
Oh, gosh. All right. Well, the first of many. All right.
We'll have to do it again next year, next immunization season.
Brandon's going to be knocking on your door. This won't air before NCPA, but it'll air after. But still right in the heart of like, I think in the middle and the thick of it for folks trying to either do it in the middle of immunizations or thinking I missed the boat if I didn't do them at that point. So I think it'll help a lot of folks in that way. So, well, good stuff, dude. Well, anything like, all right. Well, hey, I was at least, I make everyone say like one thing. And so, I don't know if we prepped you for this question, but we're gonna no prep. I know we no prep this one anyway. What are you reading, watching, listening to, or doing you're excited about at the moment? And it can be fun. It doesn't have to be work related if you don't like, that's like right now you're in the middle of vaccine season. So I'm sure it's shots in arms, but what do you have?
I'll go with watching.
Yeah. All right.
Obviously I watch sports. So but it hasn't been a great time for sports in Philadelphia over the last few weeks with the
last few weeks. I've had a great run though. So like, let's be real.
No, I'm not complaining.
But yeah. Yeah.
There's a show on Apple TV that just started. I think it's called The Last Frontier, about something going on in Alaska. And I've only watched 2 episodes, but it's been pretty good so far.
It's been good. All right, good stuff. Good stuff.
Yeah,
good stuff. Well, I'm a Cowboys fan, so I already like how you feel is how I feel all the time. So like, just just wallow in it with me a little bit. You'll be all right. Like it's like being a Bears fan. You'll understand. Y'all had a good drought for a while, at least from a football's perspective.
Yeah, the Eagles will be all right.
The Eagles will be good. So yeah, well, good stuff. All right, cool. That was we call that segment prescribables, but like I always try to like, hey, look, what are you doing? What do you like? I think Bruno. I always go back to Bruno Ching because we talked about pickleball for 5 minutes or 10 minutes on the podcast that time.
I think we need to have a Bruno versus Scott Pace pickleball.
Dude, I really think we do. I really that would be. You can't have me in there. I'm so terrible. Like
I'm not a pickleball
I don't
player.
know. I swing everything like a baseball bat, I think. But yeah, those two need to. We probably need to do a pickleball court at the next Connect user conference.
There you go. I think Cardinal had one this year, if I'm not mistaken.
Oh, they did. That's right. They did. That's right. So, all right, man. Well, dude, hey, thank you for your time. I know you're like, this is probably tough to do and find any time during the season you were in. So, really just appreciate you giving us the hour that you did. And really thank you what you're doing for the industry and the profession, man. Like everybody, I know we need pharmacies to stay in business, to be in business.
Sure.
And so do patients and communities. So thanks, man.
No, happy to do this and great to catch up.